epinephrine. Common trade name is adrenaline. It is widely available as a generic, so you usually just see it as epinephrine. It is a sympathomimetic, so it has stimulates the sympathetic nervous system. Mechanism of action: alpha and beta agonists. Alpha causes vasoconstriction. Beta 1 side has cardiac effects. Increased inotropic, chronotropic, and dromotropic effects, which is the force, speed, and electrical activity in the heart. Hits all three of those. It also has beta 2 effects at bronchial smooth muscle relaxation and skeletal vascular dilation. So alpha and beta 2 are working just a little bit differently. And then it also blocks histamine receptors. Pregnancy class for it is C. Indications: cardiac arrest, symptomatic bradycardia, allergic reactions, asthma, shock-related hypotension, except for hypovolemia. So it's anything where you need really constrict blood vessels and get the heart beating really hard and really fast. That's what it's good at. Contraindications: none in the emergency setting, really. Cardiac arrest, it's first-line drug. Hypovolemic shock, of course, if it is just a hypotension related to hypovolemia, then we want to make sure we're increasing the fluids first. MI is a contraindication, myocardial infarction, and that's just mainly because we're going to cause the heart to beat a lot harder and a lot faster, so we don't want to increase the workload on the heart too much. There's other drugs that are usually better in the case of an MI. Adverse reactions: restlessness, headache, nausea, vomiting, pulmonary edema, chest pain, tachycardia, hypertension, dysrhythmias, all those goodies. Drug interactions: it will potentiate other sympathomimetics, so they work together and they cause everything to beat faster and harder. It is deactivated by sodium bicarb, so make sure we're using different IV lines. MAOIs may potentiate the effects as well, and then beta blockers may blunt the effects, because it is beta stimulator, so if somebody's taking beta blockers, then it can blunt it. Duration effects: it's pretty quick, just a couple minutes at most. It doesn't last in the bloodstream for very long, so maybe up to 10 minutes, something like that. Special considerations: it may cause syncope in asthmatic kids. Depends on how hard they're having to work to breathe, if it's just too much for them. Concentrations commonly supplied is either 1 to 1,000 or 1 to 10,000. So with 1 to 1,000, it is 1 milligram of epinephrine in 1 milliliter of fluid, like water. We use 1 to 1,000 for allergic reactions, asthma, mixing up infusions. Anytime we give it IM, it's 1 to 1,000. 1 to 10,000 is 1 milligram of epi in 10 milliliters of water, usually. And we use it for cardiac arrest. That's what we're using it for. Alright, so some dosages here, some good stuff. For the adults, if you're running an adult and you're trying to use it for asthma and allergic reactions, then we're going to give 0.3 to 0.5 milligrams of the 1 to 1,000 concentration and give it IM, give it in that muscle. If we're running an adult in cardiac arrest, we give 1 milligram of 1 to 10,000 concentration. And we're going to do that either via IV or IO every 3 to 5 minutes while they're in cardiac arrest, according to the most recent ACLS 2015. Anyway, for bradycardia and hypotension in the adult, you can mix up an infusion route, and then you're going to run that at 2 to 10 micrograms per minute typically. So to mix that, you're going to mix 1 milligram in 250 milliliters of normal saline or D5W. And then you're going to titrate to the response to bring up that heart rate, bring up that blood pressure, all that good stuff. So whenever we're mixing that, we're probably going to just mix in 1 milligram of the 1 to 1,000 concentration. For the kids, asthma and allergic reactions, we're going to use 1 to 1,000 concentration. We're going to give 0.01 milligrams per kilogram, IM as well, muscle. Cardiac arrest and symptomatic bradycardia, we're going to do the same dosage, 0.01 milligrams per kilogram, but we're going to use the 1 to 10,000 concentration. It's going to be via IV or IO every 3 to 5 minutes. And if we want to mix up a continuous infusion, if we need to, we're going to do 0.1 to 1 microgram per kilogram per minute, so it's going to be weight-based, as most drugs for the kids are weight-based. And if in the off chance you ever have to give it via ET tube, then you're going to pretty much double the dose to get that. So keep in mind, asthma, allergic reactions is going to be 1 to 1,000 concentration, and mixing up drugs as well is going to be for the 1 to 1,000, and then the cardiac arrest is really the only time we use that 1 to 10,000 concentration.